Live, please.
Okay, good afternoon, everybody. Welcome to the module 7 of this Myopia certification course run by AIUS. The module 7 is for other options for myopia treatment, the options which are not currently available in India, but nevertheless, they are the options which are being practiced across the world. So today we will just, have some presentations on them, and then we will discuss with the experts how feasible they are and whether in near future they will be coming to India or not. So I will hand over the mic to Dr. Yogesh and Dr. Akshay. They are our moderators today. Welcome, Dr. Yogesh and Dr. Akshay. Please go ahead.
Thank you so much. Yogesh, you're muted. You're muted, Yogesh.
So, Yogesh, you can go ahead.
Okay.
You are there. Okay.
So I'll just take
Am I audible now?
1 minute. I'll take Yogesh. Just one
Yes.
second. I would like to just welcome everyone to this another module of our accredited course, which is on myopia. And I would like to thank Dr. Jitendra Jethani again for coordinating this. Of course, after all the course is over, after all the modules are over, you will receive a certificate for the same. And thank you, Dr. Jitendra, for doing it. And over to you, Dr. Yogesh, for your talk now. Thank you.
Once again, a good afternoon, respected chairperson, esteemed faculty, distinguished panelists, and dear delegates. On the behalf of the AIOS Scientific Committee, it gives me immense pleasure to welcome you all for the Module 7 of the certification course on the management of the myopia. And other options for the myopia treatment. Thank you for joining us for this important and clinically relevant session. As we know, the myopia has the rapidly emerged as one of the most significant public health challenges of our time. With increasing prevalence, especially among the children and young adults, the need of the evidence-based practical and innovative approach to myopia control has never been greater. Today's session aims to explore the additional treatment modalities and emerging options that can help us to deliver the better outcome to our patients. We honored have with us our respected chairperson, Professor Dr. Namrata Sharma ma'am, Professor and Director Dr. Jitendra Jitani, whose leadership continues to guide this comprehensive certification program. We also have the excellent panel of the experts, Dr. Mohita Sharma, Dr. Pradnya Sen, Dr. Shailja Tibrewal, and Dr. Manjula Jaikumar. Along with my co-moderator, Dr. Akshay sir, we look forward to engaging an insightful discussion. Each presentation will be followed by the focused discussion with our expert panel and allowing us to analyze the evidence, share practical experience, and clarify the clinical doubts. I encourage all participants to stay engaged throughout the session and submit their questions for the panel discussion. With that, I invite our first speaker, Dr. Chandrasekhar Chavan sir, to begin his talk on the red light therapy for the myopia control. Thank you, and I wish all a very informative and enriching webinar. Over to you, sir.
Thank you so much. Let me share my slides. Can you see my slide?
No, not yet. Chandrasekhar. Yeah, now we can. Yeah.
Yes. Great. Okay. So let me share this. Give me a minute, okay? Screen. Okay. Slide is not moving. I just have to stop share and do it again. is working. So, red light therapy is also called as low level light therapy or photobiomodulation. Um, so there are a lot of research going on at present, and the red light therapy is already in use in dermatology and in other conditions. So just a basic is for, of course, I just to set the stage, I am giving you this information. All of you know that 400 to 700 nanometers of wavelength can be detected by the human eyes, and eye being the photosensitive organ, it depends on the environment, the focusing, everything, getting stimulated, that determines the emmetropization as we grow. And uh, the since it's a vision organ, it's getting reflected and detected by the environment. Now, many times the first way of correcting vision is our spectacles, and the moment you put a spectacle, that is only the corrective thing. But the peripheral focus that happens, that goes behind the retina, that is called hyperopic defocus, and that hyperopic defocus at the peripheral retina sends the signal to the brain that you need to expand, and that's how the elongation happens. And for that, the solution is, of course, the uh, creating a myopic defocus, and that can be achieved with orthoperidology, multiple soft lenses. I'm just trying to set up a stage here, and let me see. I'll just skip all these slides. You already know. We have Dr. Jetani, myself, and Dr. Maskati has come up with this uh, point system where you can identify a child whether it's progressive or less progressive, what are the chances of complications, etc., and then you can decide that patient to be monitored in a
Slides are not moving.
I think I'm showing you some different presentation. Would like therapy for myopia. Yes. So let me just go to the main slide. So, Asian countries have done a lot of research on red light therapy, and it seems to be working. There are a lot of negative reports also about the red light therapy if it is not used properly, and that's why the protocol and the importance of guided under some ophthalmic setup it is to be done. And but it is definitely a promising theory whereby the light can control the eyeball growth. um, in 2025, one of the papers, or in fact two papers, showed that there is a reduction of almost 50% in eyeball elongation due to the red light therapy. And there are a lot of instruments are already available in the market, but they are not proven scientifically, but they are used in the dermatological setups. So uh, depending on the wavelength, the penetration happens in the skin. But as far as the vision is concerned, it is CX150 micron is what people are using for the treatment of myopia control. That is our topic today. And we have seen the different lights affect differently. We have used blue light for people who have traumatic brain injuries. The yellow light is useful. Amber light basically useful in the nighttime driving. And red light therapy, red light works for the headache and other neurological conditions. So basically there are three instruments as of now in the market, I guess. One is in China, one is in Australia, and they have some protocols. Incidentally, we also came up with the similar kind of a instrument that right now it is not available for the humans use. It is under animal trial, and we got a good, wonderful success with that. So basically, 2 sessions of 3 minutes. It's a non-invasive procedure, and it should be done in a clinical setup. So how it works is basically it increases the choroidal thickness, increases the retinal blood flow, and modulates the growth factors, reduces oxidative stress. There are a lot of research still needs to be done in that, but the OCT reports definitely shows the increased retinal, the choroidal thickness. Thus, it is making the progression slow down. So if it is used on a regular basis, even it can reduce the axial length elongation rate over a period of 2 or 3 years. And there is one Dr. Jeff in the UK who has done a lot of research on this red light therapy. He used to use just a torch with a red light, and then he came up with a lot of papers, and that is how the interest generated in the market. It can be combined with the atropine, multifocal lenses, orthokeratology, and combination therapy also works. So we do have to do a lifestyle modification when you're using this red light therapy. Still, we don't have the long-term effects. Once you stop, what happens and this and that. So the time will tell what is going to happen with this. But for me and the people with whom I'm working in the US has a lot of potential. This is the machine in Australia, it's been used. This is the machine in China that is been promising, and a lot of patients have successfully used this. And as I know, some of the reports have adverse effects also because of the overuse of this red light, which is going into 650, so near infrared, and it can hit up the hit up and damage the retinal delicate layers. So of course you have to select a correct patient for this and follow the clinical protocols for a long-term use. At least it is to be used for 3 months, 3 years. Initially, of course, you have to go aggressively, like every day or every alternate days, and then you can just keep a maintenance dose of once in 3 months, and then you can, depending on the progression, you can the doses. So it definitely looks promising, and it is going to be a good tool at our hands in controlling the myopia progression. As we have more scientific data, we will have more discussions to do on this. But as of now, it looks definitely a promising treatment. Documentation is most important so that you can follow up correctly and keep the patient's axial length measured all the time. And OCT is most important if you are doing a red light therapy, because that is going to give you what is happening actually inside the retina, and you can stop or you can increase or you can decrease the treatments for this kind of patients. So I guess compliance is the main criteria just to avoid any further complications. And you have to follow, of course, take a written consent from the patient and maintain the log, and use this wisely. Once we have wider data, the instrument is available freely at different centers, then only we can comment more in detail. But as of now, in research settings, it is working very nicely. These are my references, and we can take some questions now or afterwards.
Thank you, Dr. Chandrasekhar, for the presentation. Yeah, I just wanted to ask you, like, when do you decide to stop this red light therapy? Question one. Question two, this instrument is something that is designed to be kept in the OPD, or do you give it, is it something that the family can take home and use it and then bring it? How is it?
So, so right now, we don't advise this to be taken home because then it can be misused. And of course, we have kept some timers so it will auto shut in 3 minutes. Once it is at home, then you never know how the parents are going to use it. So initially, it is to be used as a, like a what you say, vision therapy. Patient has to come to the clinic, and under monitoring condition they have to follow this. So as of now, it is under the guidance of ophthalmologist.
when do you decide to start tapering or put them on maintenance?
So as I said, we have to monitor with the action length as well as the OCT. So OCT will give you the definite picture what is changed, and that way you can take a call whether to continue or stop. And then again you call patient for follow-up every 3 months and decide whether you want to just give a what you say extra dose just to continue that, or you can again start on a alternate days therapy. As I said, this is very new, and have to create a proper protocol for this. But whatever the guidelines people are using in the China and Australia, they are helpful for us to form our own guidelines. Of course, the Caucasian eyes are different, Asian eyes are different, Indian eyes are different. Decide our protocol depending on what results we get.
Right. Any comments from the panelists, please? Anyone from the panel, have you seen patients who have received this treatment and come, or have they questioned you about it? What and how would you deal with it?
I don't think it is available in the market right now, but yes.
Akshay, I think Shruti has got it in Chennai, and she said it's extremely harsh on the eyes of the children. This is what she has told me. Actually,
Which machine she has?
I'm not sure of the details, sir, but Dr. Shruti from MNI Hospital, she says she's got it. And but because it has very strict IEC standards, I think, as Dr. Chandrasekhar has told, you have to, there is a login credential and get shut off at 3 minutes, because that is very important, because excess exposure can cause permanent OCT changes. Your ellipsoid zone can disrupt it. That is why OCT macula has to be done every month of the therapy. First month, 3 months, and thereafter 6 months. And all these, whether it's RL or whether it's 7MX, everything are adjunct. They are not got a primary role in myopia control. You use it along with another modality. And what is preferred as far as RL is contact lenses. It could be either our MiSight kind of a contact lens, or it could be spectacles, but definitely not low dose atropine, because your photosensitivity becomes even more because of LDA associated pupillary dilatation. So they don't combine it usually with LDA, but the spectacles or the soft CLs, multifocal CLs or MiSight dual focus CL can be given. And another important thing is you should ask one particular clinical test, which they say is there an after image after exposure to the RL, because if the after image is going to persist more than 5 minutes, then you are going to have a change in your retina. So it's better to stop the therapy. So this is one particular thing. And the other thing is best corrected visual acuity also has to be monitored post therapeutic sessions, because even a decrease in visual acuity can sometimes happen. So it is not so very safe. You cannot give it in a home setting. It has to be done under professional monitoring, or the light should get shut off if they are doing home-based therapy. And that minimum of 4 hours between two therapeutic sessions is mandatory. That 4 hours gap, because what they say is 3 minutes, 2 times a day, 4 hours apart for 5 days a week.
Minimum.
So that minimum period has to be really borne. So it's not completely safe, though it's a photobiomodulator. We have to have these stringent protocols. So how well it will work in a country like us, because we can't have all patients coming to the OPD also for this therapeutic thing. And this is only an adjunct therapy. And if you give it at home, are there likelihood of misuse and the child having a permanent macula damage is a cause for concern.
So just I want to add, which I never added in my presentation, is this is unlike the other instruments which are available in the market. I don't know which machine she has been using. The only red light, that is the infrared emitting diodes are not used in my machine. What we have done is we have something called Gabber patches, and that machine is used in vision therapy already, and it has shown a lot of results, but that is used for monocular issues. I have used it for binocular issues. So it
I
is
think
more
it has to
safer
be
than
IEC,
the
sir. I
regular
think it has to be
just the red light
IEC
therapy.
specific standard, and it is not just red light alone that goes into the child's eyes.
Yes.
The mission which they are offering
Yes.
is there's a low level laser energy also along with it. It is not just only the red light of 650 nanometers plus minus 10 nanometers, whatever.
So
There
if
is
you are
also
using
some
laser,
29
you are
to
crossing
30
the
millimeters of
boundaries.
laser energy which goes into the eye. That will only photo biomodulate your retinal, whatever, your choroidal hypoxia, because it increases the flow, increases the thickness, and reduces the scleral hypoxia. If you just have only red light going in, I don't think so it will modulate that much. You need also a low level laser energy. That is why what is used in China comes with these specifications. They have specific IEC guidelines which they follow. I don't think so. Such a kind of a mission is still available in our country.
Yeah, thank you so much.
Yes, I can't talk about other machines, but yes, yes.
Thank you, Dr. Chandrasekhar. I think now we will move on to the next speaker. I would invite Dr. Sauleen Kaur from PGI Chandigarh to present her talk on red light therapy problem.
Thank you so much, Akshay, for the introduction. And thank you, Dr. Jitendra Jethani, for the invite. If I hope my screen is visible.
Yeah,
Yes.
sir. Visible, yes.
So, the previous speaker has actually spoken about low level red light therapy and how it is very promising in the large randomized controlled trials, which have been mainly conducted in China. It is promising, in fact, over promising, because it not only slows the axial elongation, it is supposed to increase the choroidal thickness as well, and is postulated to be very effective for myopia progression, surpassing all the modalities that are available. The efficacy of this therapy has been demonstrated for up to 2 years with good safety. But what the published studies have predominantly focused on is the efficacy. And there is a limited reporting. There is reporting, but it's limited for the safety and side effects. So I thought I'll take you through a timeline of how red light therapy evolved and base my talk. So that's the outline of my talk. In 2021, actually, red light therapy has been used in China for the last 3 decades for amblyopia. So the first study that came up by Jiang et al. Was on the efficacy of this therapy for myopia. It came to be so popular, it became so widely spread and used in China that in 2022, the Chinese journal said that it's actually a very promising and a therapy which is causing an axial elongation. I mean, the progression of myopia stopping by 67%, surpassing all the modalities that was there in the literature, and it quickly became very, very popular amongst the continent. By 2023, there are around 20 companies who have obtained a license for this therapy, and there came to be multiple studies and retrospective analysis that came. And the first case report of retinal injury after the red light therapy came in 2023. Only after this case report, that in 2024 there was a lab study which started studying the thermal effects of this laser on the eye, and by 2025 we had a large publication which talked about cone density changes and reversible retinal changes after this therapy. So for most of the therapies, we usually begin with the safety and then move on to the efficacy. But as you can see, we started with the efficacy of this therapy, and now we have started talking about the safety of this therapy in children. So I have outlined 5 important aspects that I think are the most important concerns as far as therapy is concerned. I think Dr. Manjula has already spoken about after images. So this is one of the most common symptoms that are reported after any red light therapy, any machine that is used. Glare and dizziness after therapy has also been reported. There's a brief blur that patients feel for some seconds after therapy, and photophobia has also been reported. Now, this after image of more than 6 minutes is a very gross measure. Most of the machines say to report after image after 5 minutes if it persists. But this machine has been used in children. The incidence of side effects is 0.088. So it's very less when you look at it like that, because they are all transient side effects. But how much are we actually reporting these symptoms? We do not know. They are all children. They are being given therapy for a very long time. And in fact, I was reading a paper when they talked about this blur. They did not find it symptomatic enough, or there was no objective criteria, but they said that children did have some reversible vision loss. And if you read the fine print, there were some participants who drop out because of after image duration exceeding. So these studies, we do not know how many children actually tolerated that after image to some extent and how many actually dropped out. So no clear data, I think, is there, and it's still a very gross measure, and that is a biggest factor of concern, I think, when we are dealing with children. As far as the efficacy is concerned, you see 67 to 80% efficacy. It somehow appears very promising, but it's over promising because there are a lot of designs and a lot of flaws in the design of the studies that have been conducted. Most of these are RCTs, but they do not have a controlled arm. So they are usually compared either with single vision glasses or with ortho K or with low dose atropine. And only one study has a sham treatment in a machine. So they are not truly randomized to that extent. And as we know, we have seen with the previous speaker, there are a lot of devices available. There are different specifications. There's no standard power or irradiance. What they talk about is the energy level, and how much is the energy level safe. Again, it's not standardized. There are a lot of devices available. I might be missing on a lot because there were so many in the market. If you look at the power, I'll just have a pointer telling you. Look at the power, and there's such a wide range of the power, and a lot of studies do not even talk about the luminance. So the total energy that is being sent to the retina with every device might not be a standard. All the trials have been done in China. I think this is one concern. There are studies coming up in Australia and Tokyo, but most of them being in East Asian children, they generally have thinner choroids, so they also display an accelerated choroid response. Is it a ethnicity driven study? We do not know. And there are people who are using this red light therapy in home based setting also in China. So we might be doing some of this therapy in some of these papers without a physician oversight. The effect on choroid, that is what is the selling point of this therapy, I think, because it's causing a choroidal thickening, which is actually helping to reverse the myopia. When you hear about it like that, it looks fantastic. But what is this choroidal thickness? Is it just uniform across the globe? So I think it's again debatable. Use of cycloplegia affects your choroidal thickness, the timing of the scan, what time of the day you are actually taking measurements. You have to consider biological rhythms, particularly because you're dealing with pediatric population. The fluctuations of 15 to 35 are actually normally also seen in the choroidal thickness, and there's no computed way of measuring choroidal thickness in most of these studies. Most of them export the images, do the thickness manually, and that might itself induce a bias. The newer indices like choroidal vascularity index might be a better measure, or give us a better idea whether actually this choroidal thickness is how much of it is actually happening. So I think it still requires a cautious interpretation, because we are not talking about the same physiological pathways as we talk about when we talk about atropine. So we are talking about increasing our vascular tone, increasing the choroidal perfusion. There is a hypothesis that the laser that is going in is also causing a heat-induced vasodilation. So how much effect is actually being generated by the actually increasing the choroidal thickness, we do not know. The fourth aspect is safety. I think this is what we are most concerned with, because again, we have pediatric population. You see, this is the visible wavelength of visible spectrum that we see, and it is towards the lower end that we are using this therapy, but it is all potentially a part of the visible light spectrum, which can cause retinal damage. So you are giving a therapy which is based on biomodulation, but is actually irradiating the macula. So once you are putting some radiation in the macula, you are going to affect central vision once it is cumulative. All these devices are talking about permissible laser exposure level, but we are not talking about the photochemical and thermal damage that is happening. You might have an increased sensitivity response. It might be a personal response. And again, after images lasting longer than 6 minutes, what do we do then? Does it have a cumulative dose effect if it still continues? So the first case report was based on this after image itself. It was a case report that was published in two journals talking about the same child. So she was a 12-year-old girl who had a decline in visual acuity and also showed OCT abnormalities. She was initially managed by orthokeratology and then moved on to red light therapy. So you see this hyperfluorescent dots, this fovea became darker in the child, and also hypoautofluorescence after 5 months of repeated red light therapy. They also observed OCT images showing this photoreceptor and RPE, damage in the form of this disruption of the ellipsoid zone. And once they, stop the therapy after 3 months, this disruption is decreased, but it still is there. The second case report talked about OCT changes in 4 patients that were kind of similar to the previous one, where they saw this disruption in the ellipsoid zone. And after stopping the therapy, there is some partial recovery, but this disruption still seems to persist after a year or so, even after stopping the therapy. You see, the children that have received or have the OCT damage was observed are quite a variable age group and a variable axil length, a fractive error of -1 to -3. And they say that there was no baseline OCT data, so we do not know how much damage was actually caused by this red light therapy. Dr. Austin group has a lot of papers on lab settings where they try to test these instruments for how do they exceed the minimal permissible limit. And 3 minutes is the cutoff. Again, we have discussed this before. After 3 minutes, it's going to surpass the minimal permissible limit that can damage the retina for any machine that is available. And they also tested on the most popular eye rising device. And again, pupillary size is something they pointed out, that pupillary size might be different in different individuals. So the amount of light that is going on is different with different machines, even if you're using the same power. Again, some OCT changes that have been reported in a recent report in JAMA. And there's also talk about the American national standards for laser safety. They say that if you have a light exposure that is causing retinal toxicity, it should not be repeated in the next 48 hours. But here we are instructing children to see the same light twice within the 24 hours period. So what happens when this gets accumulated over several years? Again, the after image lasting more than 5 minutes is very, very gross and very subjective. There is no gross measure. We should have some ERG testing. We should have some more follow-up OCTs to tell us that actually when is this damage happening and when is it reversing. Still, because of all these factors, I think we do not have any long-term data. It started off in 2021 and we're in just 5 years down the line. Long-term effects, only one study which talks about 3 years. Again, we do not know the phototoxic risk that we are having. We are expecting it to use for many years. There's no endpoint, as Akshay was asking. We do not know when we stop it. And what is the impact on the macula and the metabolism? Again, we do not know. The study that talks about therapy after 3 years has actually said that the efficacy declined after the first 2 years. So maybe it's just a photochemical photobiomodulation effect that is transient and then it goes away. We do not know again. So what is the current status now? Keeping all these factors in mind, I think China itself was the one who started the therapy and who took a stand. Last year, they had a regulatory change in their policy. You see, this all these lasers were actually classified as class 1, causing no hazard to the eye. But after reading these case reports, they have now in 2023 reviewed the guidelines and made them into class 3 lasers, necessitating more rigorous regulatory oversight. I think that is the reason that it is not available in a lot of countries now. All regulations up to 2024. After that, there is no regulation in the machine because they're not available. So by law, you cannot manufacture a new machine. You cannot sell it if it is not labeled class 3 and above. And so they have become more stringent. It's only the available machines, I think, that are being circulated. So and they also say that you have to use it above 8 years and not to be used for prevention. So we have seen studies coming on pre-myopia and red light therapy also, but again, I think they're all under the table. So I also read a study which talked about peripheral irradiation. I think we can study this therapy. It appears promising, but we need to know what is the correct way to use it and how to make it more accurate and more beneficial for the children. Whether we should do only peripheral irradiation rather than direct macular, maybe that might help. Or maybe you titrate your powers and take into account that ethnicity might also have a factor, pupillary dilation also might have a factor. It is interesting to see the eye rising itself responding on LinkedIn to this paper, because they seem to sell this therapy based on the fact that yes, it is trying to follow all the protocol, and they have set benchmarks for laser safety, and they are trying to be because they're trying to be selling it to children, and so they're trying to keep everything in mind. I think in the next year or so we might have more answers Till then, I think besides the numerous studies that do establish the efficacy, it's a promising therapy for sure. But most of them are done from China. They're not approved in many countries. The IPOC has made a group. I think Dr. Jasprit is a part of it, Dr. Rohit Saxena and Sandra. So maybe in the coming years, we will have some answer on what regulatory biases are we talking about. We need more global and more collaborative efforts, not only to validate what has happened, but also to set up standards as to when and where and how can we use it. And industry also has to increase awareness, and I think they are a big part of it. So I was lucky to be a part of this myopia consensus statement. So we talked about red light therapy, and I think it's promising, but we have to be really, really cautious while at this point of time, I believe. And acknowledgements to my mentor and also to Dr. Sahil, who shared all his articles on red light therapy with me, belonging to the Austrian group. Thank you so much, Dr. Jitendra, for inviting me here. Thank you, AIS and Dr. Namita, for doing this webinar.
Thank you, Dr.
Just if I
Savalin.
can add a little bit, that's why I have never used any laser in this machine which I designed, and we are trying to use all those mistakes and try to learn from those and try to improve on the machine that we are trying to make it. Go ahead.
Dr. Savalin, very comprehensive and very nice presentation. I think you've covered all the aspects of red light therapy that we ought to know and keep in mind. Quick questions to the panelists, Shailaja and Dr. Prajna, if you're around. Any inputs from your side?
Very excellent presentation, Dr. Savli. And I just want to say one thing, that all the studies they have mentioned about structural damage by OCT and all, but none of the studies have done the functional damage test, like by doing multifocal ERG or microperimetry. So I think they should be done for safety evidence.
Yeah, absolutely. I agree. There are only two studies actually which talk about ERG. And I think that is the way forward, because we have to look at the functional aspect. We have to have more objective markers to identify the damage before it produces a visual acuity loss.
Because I think the functional damage will occur before the structural damage. So multifocal ERG and microperimetry will be more, rather they will they will tell you beforehand whether structural damage is going to occur or not.
Yeah, agreed. Sabine, great presentation. Am I audible?
Yes.
Yeah, Shailaja.
So I wanted to ask about, the fact that it claims that it increases the choroidal thickness and the retinal thickness, and kind of becomes the only therapy which does that and reduces the axil length rather than, halting the progression of myopia. Whatever are the concerns, this is quite promising to, for patients who are really highly myopic. Have you come across how it fares between mild, moderate, and high myopia? Have the studies, kind of differentiated between these categories?
So there are a lot actually. There are studies on pre-myopia, studies on mild, moderate, and as well as on high
Yeah,
myopia.
high
And
myopia.
some are like, eye openers. Okay, they seem to work in everything. But then again,
Yeah.
all the categories are not studied together. So they are like separated into three papers,
They're not
I think.
comparative. Yeah,
Yes, they're not
comparative is not there.
comparative with
Yeah.
each other.
Right. I think we have had an excellent session so far on red light therapy. It is something that I think, interestingly, patients actually come and ask about it. Nowadays they have so much access to AI and Google. They come and ask about it. So we have had two good talks on that. With that, we'll move to the next presentation. I would invite Dr. Carrie Hersberg to speak on MiSight lenses for myopia control. Welcome, Dr. Carrie.
I think Dr. Carey's presentation is a pre-recorded one, because since we do not have any MiSight user, so we requested him to share his experience. I think video is with Dr. Chandrasekhar, is a good friend of Dr. Chandrasekhar. Dr. Shekhar, if you can share the video. No, you are muted.
Yeah, I'll try and play the video. Can you see the
Yes, yes.
Yes. Okay.
Yeah.
Can you hear also?
Not yet.
No, the voice is not coming.
Do you hear the voice now?
No, no, Dr. Chandrasekhar, not
No?
yet.
Oh, okay. Let me see what I can do. Okay, I'll just stop sharing and then I'll.
You can put it in a
Okay.
PowerPoint and then try to run it. Till that time, maybe I can
Like that?
present a presentation on 7-methylxanthine and then we can discuss and argue on that.
Yeah, I think that sounds great. That sounds fine.
Okay, go ahead.
Yeah.
So, okay. So, Dr. Akshay, should I share the screen?
Yes, Dr. Jitendra, please share the
Yeah.
screen. Yeah. Dr. Jitendra, we talked about 7-methylxanthine for myopia.
Yeah, so this is basically, I mean, I don't have any personal experience. This is just I've done a search on the net and tried to find out as much as possible about 7-methylxanthine. No financial interest, not available in the country. So basically, this particular presentation is more about asking more questions rather than giving answers. This is just to set the tone. I would be talking mainly about how it works and what are the current thought about 7-methylxanthine. This is just a metabolite of caffeine. This is a non-selective adenosine receptor antagonist. This is how it works, and that sort of affects the scleral remodeling pathways. Bulk of the work has been done by Trier in Denmark. I think way back 15 years back, they had published their first work on oral dosage of 7-methylxanthine. They had given it for almost 2 years, and it has a short half-life, doesn't have a toxicity, unlike its parent compound caffeine, and it has a poor ability to penetrate the BB barrier, blood-brain barrier, and so there are fewer CNS system side effects. This is again the mechanism of action that we talked about. It increases the collagen and fibril diameter, modulates the fibroblast collagen synthesis. The point is, it is an oral tablet which has to be given over a long period of time, and at this point of time, obviously not available in the country. May looks like a very promising agent, uh, but bulk of the work is only from one or two groups. Obviously, it is distinct from atropine, optical methods, and so there is a potential additive effect. Animal studies look robust, but there are no RCTs, no head-to-head comparison, no study which directly has compared 7-methylxanthine. Most of the work, it is very much, there is limited availability, limited approval, and evidence and experience, except from Denmark. This was the study I was talking about way back in 2008. This was published, and this was a 36 months pilot RCT. Placebo was given. But this is again just one group talking about it. Very old article, maybe in 2008. So the question is that, what was happening since so many years, why nobody has picked up. If you see the results, obviously they are very promising. Not as promising as red light, but definitely very, very promising. No rebound after stopping. Axial length refractive progression slowed down. Absolutely no side effects reported from the group. And this was the baseline age. The dose ranged from 1200 milligrams per day. Zero is mainly because placebo was also there, and they felt that there was a dose-dependent reduction in progression. Then this is what has come from the registry modeling, the first study. They felt that it had a comparable annual axial effect, but they had not done a comparison with atropine. With just that, the axial growth reduction was 0.18 millimeter over 6 years, and so they felt that this was as good as atropine or other effects. They've tried to compare how good are other myopia control methods in a review, and there is no rebound after discontinuation. So that way it scores over atropine. So they had used it for 3 years, 36 months follow-up. It did not show any accelerated, and then they waited for another 3 years, and they found that there was no rebound at all. Yes, the axial growth returned to baseline progression rate. So once you stop it, the axial length again started increasing, but there was no overshoot or no rebound as we see in atropine. Again, only one country, one particular group approved in Denmark since 2009. But except that, there is not much of a literature, but looks like a promising agent. This was the regained interest, published a mini review in 2023. This particular mini review summarizes all the animal data, human data. Obviously, the mechanism remains same. This particular review talks about the additive potential, talks about more randomized placebo-controlled trials, but we do not have any such data at this point of time. So again, the author, if you see, it is the same group, Klaus Terrier, same person from Denmark. And the limitations, obviously, in this particular article, they talk the fact that most of the data comes from single ethnicity, single country, and single group. So obviously, it needs more robust data, more multicentric studies, more randomized data, more comparison with other particular things, and sustained release formulation obviously would improve efficacy. So at this point of time, what we understand is that 7-methylxanthine targets scleral biomechanics. It reduces axial elongation during the treatment and doesn't have any long-lasting effect. Once the treatment is stopped, the patient goes back to his or her normal curve of growth. Obviously, there is no evidence of rebound. Accident safety profile, but word accident is used. But the fact that it comes only from very small group, one single group, reduces that particular point. Obviously, it is a promising agent. If it is safe, it is definitely a promising agent in future. So I think we are open to discussion. All the experts, they can and speakers can put forth their view. We can discuss the drug.
While making the presentation, did you come across any toxicity that they would expect or they anticipate or anything like that?
They actually do not. They felt that there was absolutely not much of toxicity as per their, their reports.
Okay, interesting. Yeah. Analysts, any questions, comments?
It's
I think they
always a new.
started. Yeah, start,
Yes,
please.
yes, you continue,
No.
Dr. Manjula.
No, actually, I think it started with just 400 milligram per day from 2007 to around 2000 level. And then they increased it to twice daily and then three times a day, I think. So I think they slowly increased the dosage, and the optimum dosage now per day, which is advised, is 1200. And if you look across the platform, I think this is the only thing where the scleral thickness is increased. If you look at other, even if you, as for example, Dr. Chandrasekhar's RLRR, it increases the choroidal thickness and thereby
And
the
this one is
scleral
scleral, yeah.
hypoxia. But this directly targets the scleral thickness. Even LDA does not directly target the scleral thickness. It reduces the extracellular matrix in the sclera. So I feel this has a new modality of treatment, but as he said, we haven't had any trials in our country. We don't know how the dose response is going to be in our population, but it looks promising. Again, this is also not a single form of monotherapy. We have to use it with other adjunct therapies. So with other, and even 10 years people have used it. So even in the Danish study, they started in 2007 and they've used it up to 2017. So that is a long time, almost around 10 years. So I think for a long-term thing, if it doesn't have much side effects, nothing to complain about, I think it should be a good modality of adjunct therapy. Your thoughts?
Actually, it was used as monotherapy also in many studies.
Yes. No, not many. I mean, these are the only
Only
the
studies,
few
yeah.
studies. I mean, most
of
the studies
them
was
were
used as actually
monotherapy.
monotherapy.
But any of these newer modalities, I think we can have in my opinion, I don't know. maybe we can
I
have the
agree, but
usual ones
then
along with this.
yeah,
The
but if you
combination
use it
therapy
along
should
with
be
it, then
better.
we won't come to know whether they are working or
Whether
not.
it is alone effective, yes, right.
Yes.
Mhm.
So I just have few quick, yeah, Dr. Pradnya, please go ahead.
Yes, it's always you talk about some new and relevant things, Dr. Jitendra. Just a one question, like it acts through like collagen. Does it affect growth of bones or height of the child? Because we are giving it in that period only when there is a change in height and all.
So actually, when I was trying to find about 7-methylxanthine, it does it has some role in gout and also in the renal stones. But apart from that, there was not much of
Acha.
data about it. Just few answers to Dr. Manjula's remarks on the fact that it actually started 400 milligram, and I think they got confident that it is not creating a problem, and so the dose kept on increasing. Also, they do mention in their work that it has a dose dependent response. So I mean, this is not published. This is just out of common sense I'm saying that when they must not be getting results and it was a safe drug, they tried to increase the dose to see whether it was work. So these are not published things. We are just openly discussing it. There's nobody else has the drug. It's only one of the groups which has the drug, and looks very promising because and again, just like red light therapy, when something is too good to be true, it becomes very difficult to everything is good with the drug and you have to give it oral. So you rightly pointed out, Dr. Pradnya, whether
Yes.
it has any systemic
Systemic.
problems or not. So that is what makes it very important to discuss it.
Yeah.
Yeah, I think for short periods of time, all therapies look good. It's only
Actually, in our
over.
stem cell lab, we are trying to actually explore.
Shelja, carry on, carry on.
Yes, Dr. Shelja.
Voice has
No, I
gone
was
off.
just mentioning that we just recently happened to. Can you hear me now?
Yeah.
Yeah,
Yes.
yeah, yes.
Hello? Yeah. So I was saying that coincidentally, recently, I think Dr. to test this 7-methylxanthine in scleral fibroblasts. So hopefully, in some time, we'll have some results on how it works on the cells and what are the side effects and what remodeling. So that kind of thing is.
That's wonderful.
I don't know what will happen to the result and other things, but yeah, we have recently got this project.
Is it
That's
like
It's a promising
available,
thing.
available commercially, the drug, or I mean,
Yeah, the product, yeah.
compound.
the compound
The
is available?
compound.
Okay. Dispensed in the pharmacy, or we have to like dispense it something?
Yeah. It's
We lost you, Dr. Shelja.
through some clinical trial. Yeah. Search on these scleral fibroblasts. Okay. Hello? Can you hear me now?
Yeah, we can hear you. I think
Yes,
in
yes,
between
yes,
we are
yes.
losing probably the voice is dropping off. So yeah, but we got it. Yeah.
Actually, I saw some mice studies where even 30 times more than what has been given for human consumption has been studied
Yeah.
and still doesn't have much of side effects. So, but we don't know how far to rely on these things. But it's relatively supposed to be safe, not to have much of side effects at the current dosage, even 1,200 milligram per day. The current dosage, what has been clinically taken by the Danish group of children, there are no side effects reported, and almost for 10 years they've taken complete consumption. If you take so cumulative effect, also nothing has happened on these children.
This is a little surprising because it is ultimately a caffeine derivative, right?
But it
Has to-
doesn't cross the blood brain barrier and things like that. Like how the caffeine and theobromine cross, this
Yeah.
has a limited potential. So it's the
Something probably on the heart, on the lungs, something. Let's see. It's good if it doesn't because we have more
Yeah, sure.
alternatives.
And
Very
they have
true.
tried clinically on children somewhere. That's heartening to
Yeah.
know. It's not just experimental studies.
Also, it is
Yeah.
important to understand which country it is coming from.
Okay.
Denmark, normally European countries and Danish people have a very stringent
Yeah.
health
It is.
guideline. So
Mm.
that is also very
Hmm.
different when it comes from a responsible country. I mean, nothing like that. We have to find out. We have to keep our fingers crossed and keep asking more questions, because once you are giving systemic dosing in children, you have to be very cautious.
People have given
Hmm.
pyrinzapine also previously, isn't it?
But not available. I mean, nowadays, I mean, these
Nowadays,
are
it's
these are
not there.
some things which I could find out, which is which has some promising potential. Some of the companies in India are also trying to get this in the market.
Okay.
Hmm. So interestingly, I was thinking that this 7-methylxanthine, because it acts through sclera, maybe it would be helpful in pathological myopia and syndromic myopia as well, where the scleral
Yeah,
thinning is there.
sure,
So this
sure.
could be some of the modality for those patients. I mean, we
Even
never
Don't
know.
have
for
Of
any other
course, it
thing.
has not been tested in those patients, but if we really know the mechanism how it's acting,
even for scleral necrosis and those patients.
True, very true.
and
Yeah.
if that can be, extrapolated to these patients.
Okay, so shall I go ahead with the Carrie's presentation?
Yeah, yeah, yes, you can share it.
Okay, let's see if
Yes.
this works this time. Can you hear now?
No, sorry, not yet able to hear.
Oh,
Maybe you share audio and video when you're sharing, then there's an option of sharing audio as well.
just sharing audio. Can you hear now?
No, sir.
No, no, not really.
No? No? Oh, let me see.
Doctor, can I assist?
Yes,
Hello. Yeah, can we just click on the share
yes,
button
go ahead.
once? Don't go sharing. Just click on the share button once,
Once, okay.
and left hand side you will have an option called entire screen. Just click on that,
Uh, entire screen. Okay,
and then share.
let me try this. Okay. Um, is it working now?
No, unfortunately, I think the audio is still not.
No?
No.
There are three dots.
This audio, same as system. Sorry about that.
Click on share once. Right hand side there is something called share computer sound. Just check that box.
Which one? As a background, side by side, over the shoulder, share sound. Okay, share sound. Let's see if I can.
Great. Thank you. All right.
Yeah, now we are getting the audio.
Topic and talking about it. This is a little resume of what I've been up to quite a bit here in Myopia. It's a weather. Can you remember that one in Mumbai? And then just recently I was in Osaka, Japan for a big ophthalmology event there that we did
Can you
quite a
hear
bit of
it?
talking on myopia and introduced some things to them. They were very excited
I'm here now.
to get more
No.
involved in that. So it's a theme that I have around the world success. And I've had that pleasure to be able.
I think there must be some setting.
It was playing.
As I said, content is
World's population by 2050 is going to be nearsighted, and of that, 10% is going to be high
over to Dr.
myopia, and that's a
Jethani.
critical thing
Please
because
welcome
high myopia is where the
Thing now
high
in
incidence
the
occurs
US
as far as
and
pathology. Very
pathologies.
successful,
So we had to be,
we have to be really cognizant of that and try to keep the levels of myopia below that. And the only way you do that is start early in child's life. With incidence now about 97% in South Korea, China, over 90% Taiwan, keep it under control. I brought this in because I thought, here's 85%. That's just an eye opener. It's a mission we're on now. We have 50% of the countries by the year 2050 are going to create the environment for 7% will have 50% and I've had that pleasure to be able to do
India.
that in my travels. It's an amazing number to look at. Watch the growth of the. This is a little bit of a chart to show you how I go through my taking this up and what we do following through as a patient. And we have these different interventions. Very familiar to you. It's growing. The chart we have here are the Brian Holden Institute for glasses. Brought all of our attention to the fact that we have. So,
Chandrasekhar, please pause and start again. Can you pause it?
And of that 10% is going to be high myopia. And you have it in your mind what would be the best therapy. High myopia is where the path forward for him or her. And I think it's really important for the doctor as far as pathology, to be aggressive. So we had to be,
Okay, Chandrasekhar, can you stop?
that and try to they would levels of myopia below that. And the only way you do that is if it's not suitable for the patient, they'll, you need to come up with something else. But I think in the long run, most patients will try to do what the doctor feels is important.
Chandrasekhar, can you just stop and start from the beginning and also unmute yourself, please?
Shall I do the media presentation or the slide mode?
I think video was also working fine.
Media?
Video was working fine.
So
You can just share the video.
Okay.
just pause the video to the start.
You start early and there we go.
This
This is a picture of a soft contact lens, MiSight, on the eye. So it's
Is this good?
We don't get often a chance to look at the soft lenses on the eye anymore because they're doing such specialized work. Well, it's important. You want to say that these are two studies that came out of MiSight. Big mission. One of them.
There are two videos which we can see. Can you just pause and and somehow there is an echo at your end.
I go to share. Then I will.
You want to see more than that to be effective. Remember that one in Mumbai? And then just recently I was in Osaka, Japan for a big ophthalmology event there that
Just make it in full screen, sir.
on myopia
first
and
screen?
introduced some things to them. They were very excited.
Full screen, slideshow mode.
To get more involved in that. So it's a theme that I have around the world, that we talk about, and the incidence in Asia is a big deal. It was the first alert that we got to the fact that we had a problem, And with incidence now about 97% in South Korea, China, over 90%, Taiwan, even Vietnam, 85%. So it's a mission we're on now to try to do something about this and to create the environment for success. And I've had that pleasure to be able to do that in my travels and to participate in that and watch the growth of in the field as we see practitioners taking this up and following through with
Sorry
it.
about that.
This should look
Sir,
very
nothing
familiar
is
to you.
visible,
It's
sir.
the
Nothing,
chart
no?
we have here of the Brian Holden.
Let me see.
So can you just start the video? Just the video. Is there any third-party tool you are using, doctor? Because there is an echo coming. Dr. Jadit, can we have somebody else playing this?
I have shared that to Dr. Jetani,
It's an amazing
but
number.
I think he has not received it. That's
This
what
is
he's
a little
saying.
bit of
So
a
that's
chart
why
that I
I'm trying
can
to
show you how I
Yeah,
go through my thinking and what we do
this is
as
visible.
we assess a patient.
You
And
can
we have
see
these
this
different
now?
interventions that we have. Am I
Yes,
not
sir, perfect,
scrolling
sir.
the screen or what? In the States, we've had
Okay, but can you hear it?
lens now, or glasses.
Yes,
All
sir.
right, so here's
Okay.
some pictures I have from the past. You go through this and you together. Look at the patient.
And just let it play.
Remember that often in Mumbai. You have it in your mind. What just recently I was in Osaka, Japan, for a big ophthalmology event there. And I think it's really important for the doctor to be and introduce some things aggressive and excited. Really suggest to the patient to get more involved in that. So they would begin that therapy. And of course, it's a theme that I have around the world. You need to come up with something else. But we talk about in the long run, the incidence in Asia is a big deal. Important. And I think the first alert that we got is part of your mission. You need to really get familiar with all these with incidence now about 97%, and then apply them as China with over 90% Taiwan. So even Vietnam, as we move on, 85%. We're going to be talking more and more about that. It's a mission we're on now to try to decision making, do something about this, and to create the environment for success. Get to the next slide. And I've had that pleasure to be able to do that, in my travels and to participate in that and watch the growth of in the field as we see practitioners taking this up and following through with it.
Sir, can we skip the videos? I think the videos not coming.
This is a chart we have here of the Brian Holden Institute. So it's brought all of our attention to the fact that we don't get half the world's population by 2050.
Can somebody just validate the audio
anymore because high myopia. That's a specialized thing because it's scleral.
Dr. Yogesh?
It's not working, huh?
Dr. Yogesh?
I think what we can do is we can take the video in the next module. We can just next module. I mean. Because you can share
Yeah, I
this.
think you can just do it in the next session.
Download and
I think there are lots of technical issues.
Yeah.
But the two doctors that focus is enough.
Last attempt I'll try.
We have an answer here that apparently it is. As 41% of the patients are showing no change that we got to the fact that we had a problem. Here, incidence now about 97% in South Korea, China, over 90%. They have it's a consummate number from the entire participation. Even Vietnam, some patients do really well, some feels is important, and I think
No, it's still
taking this part of your mission. You need different side play with all these 6 methods of myopia control, and then 4 out of 10 didn't change with each individual situation. And usually the answer is some did okay. As we move on, we're going to. That's not the fault of the lens of the design. It just doesn't really answer that to everybody. And so you need to do follow visits for your patients. When you one other thing I'd like to say, well, change after 3 years. Myopia. Just don't happen in the meeting. So you need to monitor very.
Yeah, you can stop it. I guess.
Request you to please also stop all videos that you have. There is an echo system.
Okay.
Dr. Jitendra, please.
I don't have the video.
So there is an echo also which is coming from the.
Yeah.
Okay, good.
Let's see. I have
There's the
turned on
link.
everything. Dr. Jetani, can you try in your email the Dropbox?
Dropbox is, I am not. Yeah, okay, I will just try to just try to find it. Can you send me on the Google Drive?
Yeah, Google Drive.
Dr. Jitendra, I have a suggestion. I think we can keep the online talk for the next session.
Everybody's voice is echoing a lot. Yeah,
Yes.
everybody's voice is echoing.
Yes, I
Okay, let
think
me
we can
see.
do
I have
that.
opened it.
Yeah.
It's coming.
If this works, okay, I'll try this one time.
And see your mission come true. You know, it's a big mission. Resume of what I've been up to quite a bit here in Myopia.
Can you
It's
hear
been a
anything?
pleasure to
We can
be
hear.
involved, to
Audio is not
contribute, to see it grow, and you know, we got to the fact that we had a problem, and with incidents now about 97% in South Korea, China over 90%, Taiwan, even Vietnam 85%. So it's a mission we're on now to try to do something about this, and you know, to create the environment for success, and I've had that pleasure to be able to do that travels, and to participate in that and watch the growth of in the field as we see practitioners taking this up.
Can you see the slide,
We
the
have
presentation?
50% of the countries by the year 2050 are going to have 57% will have 50% incidence of myopia, and that includes India. So it's an amazing number to look at. This is a little bit of a chart to show you how I go through my thinking, and what we do as we assess a patient. And you know, we have these different interventions that we have, and it's growing here in the States. We've had the Stellus lens now for glasses that has been approved the FDA. So you go through this, and you look at the patient, the young patient in your office, and you have it in your mind what would be the best therapy and the best path forward for him or her. And I think it's really important for the doctor to be, you know, to be aggressive in that, and to really suggest to the patient what they would, you know, how they would begin that therapy. And of
मैंने
course,
एक्चुअली ईमेल किया,
if
आप
it's not
अगर ओपन
suitable
करेंगे
for
ना,
the patient,
अभी
though,
मैं
you know, you
आपको
need
जो
to
ईमेल
come up with something else. But I think in the long run, most patients will try to do what the doctor feels is important. And I think as a part of your mission, you need to really get familiar with all these methods of myopia control and then apply them as necessary with each individual situation. So, as we move on, we're going to be talking more and more about that clinical decision making, in particular.
Sorry about this. I think we'll have to do it the next module. I'll email this to Dr. Jetani and we can do it again.
Sure, not a problem.
Sorry about that.
Right, I think we had some technical issues, but we had a good session. So I'd like to thank all the speakers.
Your voice is echoing.
I know.
Everybody's voice is echoing, I think.
Sir, if Sir can mute himself, then the echo will go away. Yeah, I think now it's okay.
No, I muted. I muted that.
No, I meant Dr. Chandrasekhar because
No, I muted Dr. Chandrasekhar.
No, I didn't.
No, that's why the echo is gone. No, that's why the echo is
Yeah, it's gone because I think his computer has two echoes. I'm so sorry.
Yes. No, not muted him. I muted the SL. Because sir has logged in with two devices, Chandrasekhar sir.
Yeah.
We can. If there are any questions in the chat, we can take it. I don't think there are any questions, or I have not been able to see. So. Okay, but there's a link in the chat box. Sir, voice is again echoing. So yes. There's a link in the chat box, which is the questions on this particular module. I know there are two questions on the MiSight lenses. The presentation was not there. It will be there in the next module. But you need to answer these MCQ questionnaires as a part of certification course. So the link is there in the chat box. People who are attending this for the certification should be logging and taking up those questions to answer. Even 70% of the answers would make sure that they receive the certification. We can continue the discussion if there is any point left or if some concluding remarks.
I would like to take this opportunity to thank you all, and any of you are interested in testing my machine, I'll be happy to just lend it to you, and then we can come up with some protocols or something, because I think the myopia control in India is a big thing. Children are our future, and we want to make sure that since we are in the profession of eye care, all of us can contribute to that, and I'll be happy to share the instruments.
Can you talk about your
Myopia
red lenses which you're having?
Yeah, so what happened is there are a lot of defocus theory has been now accepted, and it has been proven, and there are a lot of Hoya, Stellas, other modalities are there. The problem with all those lenses, they do not have more than plus 3.5 defocus. So it is just a blur. Still it is working 49%. So I came up with this extra power of about plus 12, starting from 4.5 to 12, and those created those defocus rings around the at 10 mm to 12 mm zone, and it seems like working. When I add a red light, like red filter to that, see, I'm an optometrist, as you know, and I've been doing this red filters for patients with dyslexia, headache, and other neurological issues, and it is working well. So I thought of adding that red light therapy, red light on the glasses. It is, as you know, it is not scientifically proven or anything, but what in my practice I used to do is I will ask patient to look at the LED light using those red light glasses, and of course the results are yet to be quantified and put it into table and measure. All right, now we are just measuring the actual length. Of course, they are not only on this red light myopia lenses, atropine, sometimes on ortho K also. So we are just not leaving it on one therapy. It's always a combined therapy. So we don't know exactly what is causing that regression in the axial length progression. So, but the red light therapy, the idea came when a lot of papers started coming in, and there was a lot of negative about it, especially from my colleagues from Canada, and that is where we thought of not putting this laser in that, but just use the stimulus of 650 nanometers, and using the Gabber patches, because the Gabber patch has been used in vision therapy and it has shown a lot of results, especially for the vision stimulus. So that is what we have incorporated in this, and we are just waiting. The animal research that we did for last 1 year has definitely shown a proven result. The actual length is not increased. We did it at monkeys and we did in some mice. Now the machine is ready for the trial. We will be of course going through all the regularities of India, CDESCO and everything. And but of course we need active ophthalmologists like you guys to test it in their clinic, and I'll be happy to lend these machines to you without any financial considerations. You can email me at chandrachavan@gmail.com and I'll be happy to share.
Okay, sir.
Okay, thank you everyone. May I ask Dr. Jethani sir to thank the panels and speaker?
So, thank you so much. Wonderful talk by Dr. Chandrasekhar and Dr. Sablin. Both the talks were really nice and very well researched talk by Dr. Sablin. In fact, I think all these newer modalities, we need to really be serious about, have some regulations, and regulatory authorities should act upon it before, it comes in the market. Because once it comes in the market, and then if we are going to find out what are the problems, then already the damage has been done. So thank you so much, Dr. Shelja, Dr. Manjula, for joining this particular webinar, and Dr. Pradnya for giving your thought process about these other options in myopia treatment, which are not commonly, or rather they are not available at this point of time in the country. So thank you for being part of this certification program, Module 7. Thank you for joining, and thank you so much, Dr. Akshay and Dr. Yogesh, for moderating the session. A word of thanks for Dr. Namrata Madam for being so kind to start this particular myopia progression control certification program under the aegis of AIUS. So thank you all. If there are any other comments, please go ahead.
Dr. Jitendra, you were very generous in thanking speakers, but I think your presentation was fantastic as well. We learned about a very new module which we haven't actually we don't know much about. So thank you for that.
Thank you. Thank you.
Yes.
Yeah, thank you, Dr. Jitendra,
Thank you
for
all.
including us. It was very interesting. All these topics, usually we start with atropine, then go to the optical and end with the contact lenses, and it's over. So newer things you always, is down the list. But this is important to know because they may come in market anytime. And if we are well aware, then we would be better position to use it for our patients. So thank you so much for this topic, and thank you to you for including us, and also to the AIS for conducting this, this accreditation course. It's very good. Yeah.
Thank you, Dr. Jethani, and all for giving us opportunity and be involved in this other modalities of myopia. And definitely it needs all these modalities needs long-term safety profiles, and then only we can include in our clinical practice. Thank you all.
Thank you all.
Thank you so much, everyone. Thank you.
Thank you.
Thank you so much, everyone.
Excellent.
Thank you.
Thank you. Bye.